comes to empirical antibiotics, we want to be as broad as possible. Now, because of your shock reaction, we anticipate that from other people also. So we go for peptides deco. Okay.
And we did not talk about prophylactic antibiotic use.
She did.
That was in the probably, yeah.
I will take the next.
We'll take it.
Not this.
They were just in prevention. She said just in prevention there has to be within 1 hour.
Good.
Prevention she mentioned.
Let's move ahead.
Anjana, was mesh salvaging the right decision for this patient?
So, as you said, this patient responded well, he went home. So, probably we are justified in salvaging the mesh. But obviously, there are certain criteria when we can justify by those criteria that whether we are saving the implant. It's an implant, basically. So, one thing was that this patient was vitally hemodynamically stable. The infection was superficial. It was not going below this. He has presented within 10 days, responded, and went home. If the infection has persisted, he has formed sinuses, fistulas, then probably the mesh explantation was needed. Or if such patients they come back to you again, you may have to remove the mesh.
Gigi sister, what are the best operative room practices that could have been done to prevent this?
So, first of all, thank you for the question. This is an unfortunate case. I can say that the SSI limit rates are within the limit of benchmark as per NIH. Yes, in our hospital. So what we follow
I
is
add a disclaimer, whatever is captured by HS.
but still. So when we think about the best operating room practices, first it comes aseptic technique. The aseptic techniques first the surgical attire. The attention towards that first is the surgical attire, the surgical scrub along with cap. It should be covered properly because the hair contains Staphylococcus aureus. It should not fall on the operating room of the patient. And then the mask should be worn not dangling around the neck. That is a practice which we see here. It should be fitted on the face properly. And during surgery, the talks or the loud speaks should not be there. Should not be any loud noises because that can cause or the breath or the droplets can come to the air and that can give pathogens and then airborne organisms can happen for the surgical site infection. Then again, movement of the people should be kept minimum.
What you're talking is very, very ideal, and what is very ideal is never very practical. You have to control.
So ideally, there should be only 7 members inside the OT when there is a surgery is going. That is the ideal. The restriction of the traffic. Then we are having the temperature controls, temperature and humidity control. Temperature should be kept 18 to 23 and relative humidity should be 15 to 60%. That inhibit the growth of microorganisms. Then we serve the personal hygiene. Those who are having eye infection, having infection to the ear, nose, throat, they should not enter the operation theater. Then the main thing is the ventilation. Everyone is wondering there is no windows in the OT, but how the ventilation works. This is simply like HEPA filters which is fitted, and before that there is a AHU, air handling units are there. So there 2 layers of filtered air filtering happens before it comes to the operating room. Then the air from the top of the table comes to the center on the patient and then circulates to the 4 vents. So sender to the 4 vents. Then again recirculate and come back. Around 15 to 20 times in an hour. But provide sir, 1 yearly. Yearly and 6 months the maintenance.
For a surface area of almost 16 by 16 by 14, you have to change it once in 4 months. Check it out.
Please, sir, we do maintenance for 6 by 6.
That is equally important. That is equally important.
They're not changing so frequently.
Maintenance is happening here now.
5 years also. What I'm saying is regular recommendations from
But even if it happens also, the air should be kept closed. That is the main thing.
That is fine.
The, if the door is kept open for a moments, then again that will not happen. Then positive, keep the positive pressure, that is 2.5 minimum, 2.5 Pascal minimum of the positive pressure should be in the operation theatre. Then the surface disinfection, cleaning and disinfection and decontamination. Before start the surgery, there will be damp testing, and in between the surgery, as sir said that the surgeons are very busy and they do not have time, so they won't allow us to keep that 20 minutes for the contact time, and that also at the end of the day there is terminal cleaning.
But this is very important.
Yeah, that is very important.
Cleaning
That is very
disinfection
important.
between the surgeons.
Yeah. Then again, sterile instruments. These as per the surgery. If it's a tissue penetrating, there should be 100% sterility. Autoclaved instruments. There is for the splouting classification of the instruments like critical, semi-critical, and critical. So always we'll have to use critical instrument for a surgery which penetrate the tissue, and for a semi-critical like endoscopy surgeries which only come in contact with the mucous membrane and the skin. And these are the main points. I think I covered everything. Anything else left? Zoning, there should be restricted entry. Restricted will be in the inside the theater. Semi-restricted like recovery rooms, and then entry the changing rooms we can enter without any problem. But once the change, we are in the OT attire, we should not move out of the sterile area.
So this was an electric case. In electric case, we actually don't want to have a higher incidence of exercise, and it is generally less. It is around 1 to 3%. Mesh infections, though they are rare, they are weak exercise, and if there are any mesh infections, we should be going for re-exploration. We can't go with salvage. But because this is a superficial exercise, mesh retention is possible. Yeah, thank you. So I'd like to start on my next case. $18,600. They had performed a USG and CT outside, which confirmed acute cholecystitis. So I would like to ask the audience, because we already had a discussion about risk factors in patients. What are the risk factors for exercise in this patient?
Now, it could go with that soft.
Like she's
Not
answering.
giving us the treatment.
No, so just the risk factors. In this patient.
Patient has a BMI of 36, so he's obese, and that causes a decrease in his immunity, which would increase chances of infections. Other than that, he's also a smoker, which causes lack of tissue perfusion. And other than that, cholecystitis is chronic. It's essentially inflammation, which itself causes an increased risk of infections.
Yeah. So patient is obese. Patient also has a smoking history. And patient has also had a history of ischemic heart disease. So these three factors alone will cause impaired wound healing and decreased tissue perfusion. Acute cholecystitis itself increases the risk of SSI. So these are the general patient risk factors which are considered when suspecting an SSI or predicting an SSI in any patient when we are operating. So if the patient has ascites, if the patient has any chronic inflammatory conditions, if he has any corticosteroid therapy, this is again not proven, but there is a controversial view about it. If the patient has obesity, patient is diabetic, and that too uncontrolled diabetes, if he's in the extremes of age, he has hypocholesteremia, hypoxemic conditions, any peripheral vascular disease, he has postoperative anemia, irradiation to the surgical site, recent surgery, remote infection, skin disease, and undernutrition. So this patient underwent laparoscopic cholecystectomy as a planned procedure in a peripheral hospital. From his intra-op notes, we know that there is no bile spillage. Drain was placed during the surgery. The gallbladder was removed to the umbilical cord, but without any bag. He was given Supasef 1.5 grams twice a day for 3 days and was discharged on POD2 after removing the drain. Suture removal was done on POD10. So this was his post-op after suture removal. So what can be the procedure-related risk factors responsible for SSI in this patient?
So in this case, as you said, this was done in some peripheral hospital. The thing will come to my mind is how was the sterility about the instruments in that setup. Very important factor, especially with laparoscopic surgeries. Secondly, acute cholecystitis in itself is a risk of infection. It's a case of acute cholecystitis with recurrent biliary colic or recurrent attacks of cholecystitis. So we don't know about the duration of surgery. So in general, duration of surgery is also in risk factor for developing an SSI. If the surgery is of long duration, the risk is more. Then there was no bile spillage. If there is a spillage of bile or intestinal contents, it again increases the risk. In this patient, it was an acute cholecystitis case, and the BP was removed without putting it into a bag. Directly came in contact with the tissues. So again, it increases the risk. Drains are also a factor in increasing the risk for infections, which was there.
So general treatment factors which can increase the risk of SSIs are these. If it is an emergency procedure, patient is having hypothermia during the surgery, inadequate antibiotic prophylaxis, prolonged pre-operative hospitalization, or a prolonged operative time. So this patient presented 2 weeks post-operative to us for the first time with pain, swelling, and urination, and also water discharge from the umbilical and epigastric roots. So I would like to ask the audience: is this superficial SSI?
It is superficial because it's still within 30 days of the operation and is also limited to the surgical incision.
So I would say yes. In the beginning, we'll call it as a superficial until unless we had done the investigations with an ultrasound that there is no deep cavity collections. It's not going below the fascia. Till then, yes, we will call it as an SS, superficial SS.
Yes, so ma'am has already explained why it is a superficial SSI. Nandini ma'am, if you were the anesthesist for this case, what precautions would you have taken to prevent the SSI in this patient in intraoperatively?
Yeah, this patient had come on a semi-emergency kind of surgery, so there is no scope for optimization as such. So we have to consider that this is kind of systemic bacterial load can be there because of the infection. So in this case, apart from whatever optimization in his systemic illness we have to do, that we should be doing before the surgery. But while doing the intraoperative procedures, anything like putting a peripheral line or central line, you have to take all the asepsis, take all the precautions to prevent any kind of infection. Putting a epidural or putting a central line should take all the aseptic precautions, including all the sterile equipment using all those. Then there are some certain factors which lead to SSI. For example, intraoperative hypotension, which is a big factor. Then maintaining oxygenation, because that will the tissue perfusion is most important for healing later on. Then any intraoperative sugar surges, that also you have to take care. Then antibiotic at this within an hour of starting the surgery. Then hypothermia, prevention of hypothermia, because hypothermia leads to vasoconstriction, which also again leads to the decreased vascularity and the prone for SSI. And then using all the whatever we are using for anesthesia, like using the mask which are disinfected properly, using the air circuit, the breathing circuits which are ETO or new one, and using all the sterile IV fluids, and taking in fact during the procedures itself, giving any blocks or something, you have to take all the precautions. So
Swab and biopsy was taken for the culture and gram staining. The wound was dressed daily, and pus was incision drainage was done to drain the pus. Antibiotics were started empirically. Ma'am, Anjana, what infections are specific?
procedure, I would say we can say one Part is infections which are related to such as laparoscopy, whether you operate on gallbladder, you operate on intestine. Another aspect is depending on the organ which you are operating. So there are two spectrums of it, especially with laparoscopic procedures. And as I said, this patient was operated somewhere outside, and I already mentioned that there's a risk of, I don't know how they are sterilized, so risk of infections. So whatever routine infections we see with organisms colonizing the skin surface, like staph, we can expect that. Especially with gallbladder, is this gallbladder was removed without a bag and it was acute cholecystitis. Normally we see is anaerobes and gram-negative bacilli and anaerobes. And another third important, which normally we don't see in our setup, but somebody in remote area where sterilization is questionable, we sometimes get to see non-tubercular mycobacteria also.
Riyashik sir, what antibiotics would you prefer to start with?
So I'll give two answers, I guess. There's the socially acceptable Harrison's back answer, ceftriaxone metrogyl. In our setting, uh, there are three levels, right? So if you're looking at covering skin flora, you're looking at covering flora from the gallbladder. So Enterococcus, E. coli, Kleb, anaerobes. Let's say you give only piperacillin tazobactam. Yeah. You will cover skin flora up to MSSA, you won't cover MRSA. Okay. You will cover E. coli and Kleb, which are ESPL producing and not co-producing OXA1. It's very difficult to untangle that in 5 minutes. You will cover all anaerobes, you will cover penicillin sensitive Enterococcus. At Ruby Hinjewadi, 9 out of 10 patients will be fine with just piptaz. At main Ruby, for a patient like this who's been to the hospital before, has undergone angiography, has been in this environment, they are going to be colonized at the very least with gram-negative bacteria which are OXA1 co-producing. So after piptaz, your next level is meropenem teicoplanin. In our setting, most of the times, meropenem teicoplanin is what you would give over here. And it is not an exaggeration. It is based on our local antibiogram. So mero will cover thoroughly ESPL, GNB, anaerobes. It won't cover enterococcus. Penicillin-resistant enterococcus need a glycopeptide, so Vanco or Tico. So mero Tico. And then now here it won't apply, but in someone who's let's say been in the liver ICU for 2 months and then they develop a infection and they need surgery, then they're colonized with carbapenem-resistant gram-negative bacteria and vancomycin-resistant enterococcus. So in that setting, it will be daptomycin, ceftazidimab, astrolab, metrogyl. So there are these various strata, the Harrison's socially acceptable answer, and the three strata in our setting. So we have to judge clinically where this patient falls. Probably this one would be, I would start this patient on teicoplanin and meropenem. And then when the culture grows, I would de-escalate brutally. I mean, there's no doubt that we have to de-escalate. Previous patient, Mero Tico. MSSA, immediately stop and change to sapazole, like you all have done. Right? There should be no fear with de-escalation.
But there is one point. We in urology do this generally treating UTIs, community acquired UTIs. We started with a simple antibiotic, and we are going to wait for the manufacturing technology report anyway. Maybe about 2 or 3 days we're going to get the report. So this kind is not an ill patient. Why don't we start a simple antibiotic which is cheaper and good, and wait for the microbiology report, and we start the antibiotic there.
So,
Rather than meropenem teicoplanin, that's a bit too much.
piptaz, because you have room for failure in the sense in the next 40 to 72 hours, if the counts keep increasing, etc., and by then you have a culture report, you have room to escalate. That is fine. If the patient is in frank shock and organ failure, you have no room for escalation. Then you will cover broadly and you will de-escalate. No one will fault you for giving piptaz monotherapy. It's just that in our practice now, we have a good idea of the numbers. So, we look at everything as a gamble, throw off the dice. And more likely than not in today's world, you will fail with piptaz at main Ruby. At Ruby Hinjewadi, we would not think of starting with Mero Tico, the kind of patients that come with the flora in that hospital. Everyone will respond to piptaz over there. So I stand by what I say over there.
If I can play a devil's advocate over there, it's a patient with a post-site infection, post-cholecystectomy. He's not sick, just has discharged from his wounds. What if we open up the wounds, allow this to drain, take a pus culture, and
the surgeon's risk appetite is like that, then no problem. We have no issues at all. But the reality is often not like that. No? So, absolutely. But the thing is, uh, uh, someone said earlier, what if we just debride and let it be? I don't think it is possible to surgically remove the entire infection. There will be some bacteria left in the margins. You will need a couple of days of antibiotics to cover that. But your approach is also perfectly fine, very honestly speaking.
So what do you do actually normally in such
Let the
scenarios?
stitches out.
Drain
Let
it.
any collection which is in the subcutaneous tissue drain out. Take a first step. And probably not escalate, or he can continue to take antibiotics if he is taking it, but then not start anything.
You till you get the surgery.
One thing I had not followed in USG abdomen was showing any deep nothing over there. You're absolutely right. Yeah.
Superficial SSI would not always need antibiotics.
Correct.
So, ma'am, how would we prevent NTM infection? I'm gonna-
Prevent NTM, I think as a surgeon, most important for me is the instrument should be well sterilized. That is, they are autoclaved or ETO'd. I won't use the instruments which are like just washed with running water and kept in some boxes and all this. It should be a RO water where they are washed and sterilized well. That is the most important thing to prevent NTM.
So NTM is basically non-tubercular mycobacteria. Mycobacteria are a kind of a species which are very difficultly, they will be killing, they will not be killed by the normal disinfectant simple what we are using. So as madam said, depending upon the type of the instrument, it will need high level of sterilization. That can be autoclave or ETO or plasma, whatever it is. So that is most. So even if you are in a hurry and want to finish back on back cases, make sure that the adequate number of sterile equipments or instruments is there rather than compromising on the quality of the equipment. Sir wants to say something.
So, question of when it comes to NTM, I think it's entirely the surgeon's responsibility and the OT team's responsibility, because this, we used to see this formalin chamber. This formalin chamber is like a breeding ground for the NTM. Most of the time, the problem is that the instruments are not cleaned properly. There is some organic matter which is left behind. The water which is used to clean the instrument is not RO. So, and then they go into a formalin chamber which is not adequate to kill the NTM. Secondly, if the water is not RO, even if the surgeon has scrubbed up using that water, I think probably using a hand sanitizer is mandatory, because sometimes that can also be the source of infection.
Mycobacteria, atypical mycobacteria or NTMs are everywhere. They are in the air, soil, water, they are everywhere. So whatever points sir has said are correct.
Vijay sister, how to clean and sterilize our laparoscopic instruments?
Sir rightly said that we are using the formalin tablets, but that was a practice even before, but now it is 100% stopped. We are not at all using the formalin tablets, and even Sidex also not used. Once in a while, if the instrument is fallen down and we do not have a separate one, then rarely we use that Sidex, dipping of the Sidex instruments. Even if it is there, we are using this Sidex OPA. That is highly disinfectant within 5 minutes. If at all we are using in between. Otherwise, the cleaning and sterilization means there are different methods of sterilization is there. Before that, cleaning first with the running water, and if it's a laparoscopic instrument, we will have to dismantle that instrument. There are 3-4 parts are there each instrument. The hollow parts are there, crevices are there. So all that we will have to put in an enzymatic solution. That is usually we are using here Liquzyme, 8 ml per liter, and we are dipping it for around minimum of 10 minutes. Then we will manual cleaning with the brush, and then again it will go for the ultrasonic cleaning. There also they are using the Liquzyme. Then it go for the sterilization. There are autoclaving. If the metal instruments are there, that will go for autoclaving. If it's laparoscopic, specifically it is heat resistant, then it will go for the plasma sterilization and even ETO sterilization, because the time consuming ETO takes around 16 hours, whereas plasma takes only 1 hour. So as per the availability, whichever we need first, then goes for plasma, otherwise ETO. So, and there are chemical indicators and biological indicators which are used in the autoclave machines. That biological indicators daily once in a day, and the chemical indicators that is inside and outside, that is each pack it is there.
Make a point. I'll just make one more point for the knowledge of all the students that there is something like a QC check for laparoscopic or hollow, endoscopic instruments. What they say is you should push a sterile water or sterile saline through the scope and culture it. Look for ZN and culture it for NTM, because that is your QC check for the scope to make sure that there are no NTMs. So that is
we are
very
doing for
important.
endoscopes.
No,
Endoscopes we are
15
doing.
days.
To
But we are
educate
doing that.
the residents that is
So
one of the
every
QC
15 days we are doing that. The OT team sends us the swabs and the flushed saline. And also this solution what GTA OPA GG Sisters said, that also has the QC parameters, because this is once prepared we can use it for 7 days. So every 3, 5 and 7 days the strip testing is done, and that the records are maintained, because that solution should not be the source of any other infection the instrument will have.
If the number of dippings are more, that will get diluted. So that is one.
So these are all, right. So they will not just come with the swabs. The gold standard method is the NTM. That means the AFB culture basically. The AFB culture is not done on any of the swabs basically, because they are deep-seated infections. So the swab material will not have the kind of mycobacteria which can be cultured. But now you'll say that, ma'am, NTM culture will take a long time. Most of the times these are rapid growers. So usually within 8 to 10 days, the report usually comes if it is a rapid grower NTM. But till that time, we can use simple tests like ZN test, the ZN or AFB smear, and even NTM PCR can be sent. But again, the disclaimer is same: do not send the swabs. You can aspirate the frank pus which is there, or the biopsy or the tissue sample. That is the ideal sample for this test.
Treatment for NTM.
Most of the times, these are what we call rapidly growing NTMs. So Mycobacterium abscessus, Cleveland, Fortuitum. We see maybe one a month. Most of them have been operated outside, oozing from the port site months after the surgery has been done. So it's a bit tricky. The one antibiotic that is sensitive most often is actually amic acid. 95% of all of our rapidly growing NTM are amic acid sensitive. So most regimes which have successfully cured these have included amic acid in some shape or form. Now the question is how long? Nobody knows. Basically, as long as you can get away with, as long as the patient can tolerate. So which means the patient will be taking OD amic acid 500 or 750. You'll be checking the creatinine every third day. You'll be doing a pure tone audiometry once a week to make sure there's no hearing loss. You can't wait for them to report hearing loss because they'll notice it only when it is moderate to severe. Sometimes they tolerate it for 3 to 5 days, sometimes they tolerate it for 3 weeks. But amic acid, as long as you can get away with. Beyond this, we normally use 3 oral antibiotics, right? It will be any of the following: linezolid, minocycline, cotrimoxazole, and macrolides. The backbone will be a macrolide, either clarithromycin or azithromycin, one of these two, right? So, but antibiotics by themselves will not cure the infection. It requires a thorough debridement. So, the surgeon needs to debride it as if it's a cancer. In the sense, there has to be a free margin around. And very often there is a round 2 and a round 3 required. In the sense, even after you've done a debridement, once you've treated thoroughly, a couple of months later, a new lump appears near the surgical site, again, a new abscess forms. So, we should not shy away from debridement. So, antibiotics are just there to kind of clean up whatever is left behind. Yeah, so, it's a combination of this, that, and it's a marathon for the patient. They get very frustrated, but they are curable, and they usually don't go deep. It'll always be up to the subcutaneous layer. So they never kill the patient, but it causes a lot of local scarring, a lot of hospital expense. This is normally how we treat NTM.
In this patient, to prevent, we should optimize the preoperative factors, that is movement cessation, and to reduce the VMI. We should standardize our procedural safeguards, that is to remove the end of any infected gallbladders with bags and to make sure our instruments are sterilized. Early recognition of the infection and targeted treatment always helps with the SSI level.
So this patient grew NTM.
No, not happened. He
because we have to cover everything.
Last ask a question which has not been covered before. Yes. A 50-year-old farmer came to the emergency department with complaints of acute colicky abdominal pain and various vomiting and constipation. He is a known diabetic with uncontrolled, even with oral hypoglycemics. He underwent appendectomy 30 years back. On examination, he was febrile. He was tachycardic. BP was normal. Per abdomen showed signs of diffuse peritonitis. On investigation, total counts were elevated with neutrophil predominance. Random VSL was elevated. CRP was 56 and procalcitonin was nothing. On X-ray, there was no peritoneum and CT abdomen showed bowel obstruction with perforation. In any emergency setting, Nandini, can a patient be optimized? To what level do you think this patient could be optimized?
I think we have covered in previous two similar. Now it is emergency. So as I told earlier, the same precautions you have to take for all this and to try to avoid all those risk factors.
Patient underwent emergency expiratory laparotomy with adhesiolysis and resection of perforated bowel segment. He required inotropic support during surgery, which was continued postoperatively for 1 day. Postoperatively, patient was started on clear liquids after 48 hours and chocolate was started after 96 hours and was discharged on postoperative day 6. Vein was placed near the anastomotic site, which was removed on day 3. He was started on antibiotics. He received antibiotics for 5 days. Piperacillin, tazobactam, and metronidazole was used. At the time of discharge, total leukocyte count was near normal and wound was healthy. So this was his wound at the time of discharge. So
This is contaminated. We discussed this is a contaminated case. And rest all emergency and contaminated. Other factors we discussed.
so was antibiotic use adequate? Is a question.
Proceed which is
So
for the
we don't need Metrogyl here because Pipras has complete cover of all anaerobes. So that is one easy to change practice in our
we
institute
need
here.
to change it.
We need to stop
That's why
giving
I put it
Metrogyl.
here.
That's a
Piptas
good
and
point.
metro we don't need to give to them. So we don't need to give to them. Piptas covers analysis.
So I think this point is taken by no need of metro.
No.
Very important point.
Even I came to that.
So he was readmitted on postoperative day 8 because he presented with low-grade fever and abdominal pain and vomiting. He was febrile, pulse rate was 102 per minute. On examination, there was induration and tenderness in the lower part of the midline. 2 stitches were laid open and then less than 1 ml of pus was drained from the indurated area. So how to diagnose an SSI in this case, I would like to ask the question to the audience.
Initially, we can do sonography to look for the correction, but contrast the CT will be better.
First thing I think you need to see whether it is superficial or shallow. So you will obviously open the stitch, 1 or 2 stitches, you drain the pus, you take a sample as advised by Dr. Upai. But you will like to see, because it was a contaminated case, a dirty wound, you will like to see if there is a deep collection. You have done a resection and anastomosis, so you will like to rule out there is no leak. So you have to do some further investigations, like basic is ultrasound. Many times immediate post-operative period ultrasound may not tell us about areas like deep in the pelvis or some diaphragmatic area. So you can directly go for a CT also. It's not necessary that you go directly for a CT. You can do an ultrasound and then if required you can go for a CT scan to find out if there is a deep collection.
So his he was readmitted and started on antibiotics. Injection hydroquinone was started. Total leukocyte count were around 19,600. CT scan showed approximately 70 cc of collection in the pelvis. So this can be considered as an organ space infection. We have further classification into deep SSI and an organ space infection. Deep SSI is any infection at the surgical site which is less than 30 days, or if an implant is placed within 1 year that is involving the deep tissues, that are those your fascia and muscles. Again, along with that, it should have any one of the following criteria: that is purulent discharge or an abscess in the deep space, which can be either radiologically examined or can be found on a reoperation. It could be diagnosed by a surgeon, or in the patient should have fever, pain, tenderness, which can lead to a wound adhesions, or we are opening it to drain out the abscess. Organ space infection, same infection, similar to the deep space. If it is in an area where there is where in the surgery where they have opened or manipulated, or if it is collecting in any organ space, or where if they have placed any drain surrounding that area, if it is collected, then we call it as an organ space infection. Rupali ma'am, what are the common pathogens we see in such cases? Which are deep space or
Yeah,
organ
it's
space?
already covered basically a combination of aerobes and anaerobes, and because it was explorative laparotomy, the gram negatives will be predominantly E. coli, Klebsiella, Pseudomonas, Proteus. Those will be predominant, but both aerobes and anaerobes.
Anita ma'am, how do we manage this patient?
This patient will come with, I think, high-grade fever with tachycardia, so we need to admit him. Probably will be dehydrated also. We have to start. First, we drain the pus. We open the stitches, see if the pus is coming out. We start IV fluids. We start antibiotics. We get radiological investigations like ultrasound if required, a CT scan, and if there is a deep-seated collection. And if it easily access, I'm just covering the other question also. So if it's a deep-seated infection which is amenable to radiology, I will go in for a USG or CT and send the pus for culture and change antibiotics accordingly. If patient settles, well and good. If he doesn't settle, then I may have to explore him. Or another case, if the respiration shows intestinal contents, then there is a possibility that I may have to explore him.
Jomi sister, I want to ask one. So we had two cases which were operated outside and one which we have operated in our hospital. So whenever it comes to SSIs, do we have any surveillance protocol to pick up SSIs in the wards or anywhere?
Special thank you for asking this question, because surveillance word itself is a real pain. The reason I will explain, because surveillance require intra-departmental cooperation, because it is SSI. We have to track the patient for, as you already mentioned, for a longer period, like right from the admission to 1 month. If it is implant case, you mentioned it 1 year, but now it is 90 days. Up till 3 months, we have to track. So it's a long journey. So first of all, any patient who is undergoing surgery, the first cooperation should come from the surgeon and assistants, because there is something called as Munshi ma'am already formulated that form, something called as SSI performer. I think Gigi ma'am is carrying that form also. It has beautifully designed with demographic data, pre-op scenario, intra-op and post-op. So that has to be mandatorily filled by the surgeon and the team before the patient moves out from the hospital. So that is moves out of the OT. Also, it has got post-op history. So before the discharge, that form, complete 3 aspects need to be filled. So that is one. Second one is like when the patient comes for follow-up to the OPD, it may depends upon various surgeons. Like some patient may come on 7th day, some patient may come on 14th day. The actual scenario of the wound they will understand while they doing the dressing or suture change or something. So that time the sister, the OPD nurse is assisting them. As I mentioned, we have to literally track the patient for 1 month for an implant case up till 3 months. So we have to give a call because patient is at home. So that calling factor and that helping, collecting the data is done by the recovery team. And last but not the least, in case if OT team forget to inform or OPD team forgets us to inform, ultimately whichever swab or pus or anything from the surgical site, any tissue or anything is gone to the micro lab, we can assess the report from them. So with that method also, from the lab tracking system also, we are able to track. So it is a 4-level process, but as of now, from the first level only the gap is there. Why that form is important is, if you are filling that complete form only, we will understand that what went wrong and in which phase. This is very important. So also from the OPD, each level it is important. Also from the follow-up status at home, also from the micro lab.
Yeah, so please, it's a request since we all are under one roof. So it's a request because you have to understand that this SSI form hard copies have been stopped. It has now been uploaded in the EMR, but the confirmed SSI cases when we discuss with Rupali ma'am and Devashi sir, what we are facing is like retrospectively we are making the hard copy by seeing the old records, and then we are only filling everything, and surgeon it's not like easily not approachable, so behalf of surgeon sir and ma'am is signing. So since it is a good platform, please request to all the residents to start filling the SSI form. Thank you.
Yes, yeah. And also, whenever you are sending the pus sample or tissue for the testing for the culture, the microbiology requisition form. Because if you will not write anything, we will not understand that probably it is linked to SSI.
From the OT, after 1 month, we call religiously, we call all the patients, but I don't know whether they are giving the right answer. We ask some questions also if there is any redness alongside the wound or any pus discharge or any fever. Whatever they are telling me, write it and we inform if he feels that if something related to the SSI, then to the ICU.
Follow up, very important.
So
The
basically
residents, you all
inform
have to be
surgeon
very,
or
very
the
clear that the
microbiologist.
patient has to follow up in the OPD. And if you find that there is pus or fever or swelling, you should take the initiative, fill the microbiology form and send for culture. And write details, like Dr. Rupali said, write the details. Patient operated on this day for this surgery. What antibiotics were given, everything should be written.
Ma'am, that is going from the OT nurse.
Are
That
you
first
talking
part.
about the
OPD.
Follow up with the patient comes for dressing to the OPD.
Yeah.
That is where the gap is.
Because finally, this is improvement activity. The more SSI cases we're going to track, we will go back and do the CAPA basically to prevent the further SSIs.
Thank you.
I'm sure again, so many new points came up to this, revisiting this problem of SSI. I'm certainly very glad with it, but I've learned a lot through this. But things are not, I mean, you go on learning things, you know, getting your experience more and more on this. But at this stage, what I would say is that we will stop the panel discussion. I thank every panelist for it. I particularly appreciate Mr. Jovi and Mr. Gigi for making their point so strongly and emphasizing their role in control of sepsis in the theatre. So I really appreciate everybody for putting in their efforts. Thank you. Now, this will be followed by two short talks. One by Dr. Rupali Suryavanshi. She's going to give us a quick data of microbiology analysis, right, Rupali?
Sir, I thought that would be another series, so I haven't brought the data.
So, whatever. What do you want to say? We're going to get the data for some surveillance data, maybe?
No, sir, I thought that will be later on, not today. So
Okay.
I haven't bought any slides.
Okay.
But yeah, just I can just
No,
tell
no,
you
no,
last
not
1
very
year,
sure.
yeah. Last 1 year from January 25 to December 25, there were total 28 cases of different types of SSI amongst around some 8,500 surgeries. So our SSI rate usually with this figure comes around with the 0.3%. 0.3%. But again, this is with the kind of a tracking system what Jomi has explained. Whatever we can extract, that only it is data. Probably there are more cases, but we are not able to catch hold of them.
0.3% is documented.
Yeah, 0.3% is documented.
And we don't know, but what comes to the OPD afterwards, it has not been documented. So it's presumably is much higher than what we believe.
Yes.
Isn't that
This is
right?
just, I think, tip of iceberg.
Fair enough, yeah. Good. So that's about it. And Dr. Devashish, would you like to have one brief talk about antibiotic stewardship on
So basically,
compound cases? And you guys come here and speak. Oh, there.
so how do we approach SSI from ID? So when we get a reference and we see the patient, it's basically a series of questions in our mind. The first question is there an SSI? That is normally very easy to answer. It is obvious clinically whether it is there or not. Right? Okay, so there is an SSI. What organism is causing the SSI? Most of the time, the data that we have is on the basis of swabs, which may represent the pathogen, or more likely than not is a commensal, right? But very often we have to work with what we have. Sometimes it is obvious on the basis of what has grown that this is obviously not the pathogen. If it is a coagulase negative staph, or it is a coronary